You are listening to the Eyes Are Health podcast with your host, Dr. Josh Gilden.
Disclaimer. The information discussed in this podcast is for educational and informational purposes only. Always consult with a qualified healthcare provider regarding a medical condition or treatment. The views expressed by the guests and hosts are their own and do not necessarily reflect those of any affiliated institutions.
This is awesome. Welcome to Dr. Aaron Herrera. I got that right?
Yeah.
To the Eyes Are Health podcast. This episode is cool. I'm excited about it because every episode I've had so far, I've actually had the ability to know the guest pretty well beforehand. But this one, we are going in fresh. I met you. This is time number 3, right?
Yeah.
So if it doesn't go well, I can be like, I didn't really know you. It's fine. That's why it didn't go well. But it gets to be a fresh start for me, which I think if I'm able to ask interesting questions, I think the audience is going to have a good time too. So welcome to the Eyes Are Health podcast.
Well, thank you so much for having me. Thank you for making the time and excited to be here.
So you've had maybe a circuitous route. You know, you didn't take the direct route to get to where you are today, to this beautiful blue room that we have here. Wasn't the average kind of, not that there's an average. I think every medical journey experience is pretty, everyone has an interesting story. If you got to this stage of practicing, very few people have a very direct route. It's like, I did this in high school and I got all the A's in college. Then I went to medical school. I was the best medical student. And then I got into the top residency that I wanted to go to. And now I'm practicing exactly where I want to practice. And I'm practicing exactly how I want to practice. Like, I just don't think maybe it is, maybe because I'm the exception. I don't think that's the rule, but I don't think that's the rule. So I'm just curious, did you always anticipate, studying in Mexico and then coming to America to practice?
No, that's a very good point. I knew that I wanted to be a doctor when I was about, I would say, 16. At that time, I was in my hometown in Chihuahua, Mexico.
Is that named for the dog or after the dog?
So the dog comes from the state of Chihuahua. So that's why the dog is called Chihuahua dog.
Gotcha.
Yeah. So when I decided that's what I wanted to do, the first question was which med school, and what resources do we have as a family. I am from a very humble beginnings. My parents both professionals, but things in Mexico are hard, so they struggled a little bit with being able to keep up with the expenses of keeping a family.
What kind of work did they do?
My dad is an electrical engineer, and my mom is retired right now, but she was an elementary school teacher. I am the eldest of my siblings. I have 3 other siblings that are all physicians as well.
All physicians?
Yes, and they are all in the United States right now, too.
Wow. So proud parents, likely.
Yeah. Through a lot of effort and struggle and sacrifices, they help us go through med school. But I was the first one that decided that I wanted to be a doctor. Actually, my dad, when he was younger, he wanted to be a doctor, and he was not able to pay for the med school. So he went to engineering school for that, but he was in med school for about a year. And then he had to switch careers because of he had to maintain himself. So it was not easy for him to do both things. So
that's incredible.
Yeah.
And you set the standard for your family. I find that interesting because I'm the 5th out of 5, and a bunch of us. My oldest brother, who's an EMT, who I obviously looked up to, and that's why I ended up becoming a doctor, because I saw him as an EMT. I thought it was the coolest thing in the world. And so I emulated a lot of what he did. Now we tend to compete a lot in life, but that's a later story. But he set the precedent for the medical experience, and a lot of us kind of followed suit in some fashion. One is a dentist, and then I have another brother who's a plumber, but he actually works in a hospital, and then obviously I work in the healthcare setting. So we all kind of got this bug from him. I don't know where his came from, really, but I'm curious, I guess, was your motivation from your father and just seeing what he wanted to do and just trying to kind of fulfill that, or was it something else?
So, to be honest, at the beginning, it was based on a biology class that I had in high school, and it was not per se human medicine. We were having this lecture on this viruses that have these little legs and the body with the DNA in them, and then they step on the bacteria and inject their DNA on the bacteria, and then make them explode, and then they replicate again. So that sounded pretty fascinating to me at that time, and I also started to read a little bit of anatomy and biology on my own time, and I must say that I come from a family that is religious, and I always saw the human body as the masterpiece, God's masterpiece, right? So when I started looking at anatomy and stuff, I felt that I was so privileged to be able to see or study God's masterpiece. So it had also a spiritual component to it. So, and I thought that if I were to choose a career, the one that I wanted is to understand the God's creation through the human body being its masterpiece, and also how to help people heal when they got sick. So that's a little bit of the background on how I decided to become a physician. Yeah.
That's awesome. I think two thoughts come to my mind when you were saying that. The first one is that I think there are two kinds of people that get into medicine. I feel like you are like the science-driven kind of guy. Like you started reading and hearing science, like this is awesome, and you're like, I have to do it. My personal journey, I imagine this is the opposite of that, is just like sciences to me were the impediment to getting to medical school. Like I knew I liked history, I liked other stuff, and then all of a sudden I had to do all these sciences, and I'm like, oh, this is crazy. This is so hard. Obviously pushing through it and figuring it out, but and then I saw people who are just like naturalists. They're like, yeah, this is great. Science and chemistry and physics. And I was really like grinding my teeth on all this information. So I feel like there's two different people that really go into medicine. Both can become fantastic clinicians, but it's two different ways of looking at it when you're going in. And the other thing that I thought is that the first thing to go in medicine, or no, sorry, I don't want to say the first thing, but one of the things that is easily lost when someone is working long days, long hours, hard shifts, emotionally challenged, is remembering if you're of the religious bend, that it's a privilege, really. I mean, even if you're of the secular bend, but certainly if you're of the religious bend, it's like a privilege to take care of creation and human beings. And obviously, animals and all those kind of things. But when you're taking care of a human being, who you can relate to, I think one of the classic things that strikes me is when you see elderly patients sometimes towards end of life, and they can be in very tough situations. I mean, there's a tremendous amount of social structures that are challenging, and especially being an ER physician and working in the ER, they come in a variety of fashions. And sometimes people will discount them because it's like, well, they're getting older and it's part of the natural course of life. And unfortunately, there's not many people around them. But just to always remember, like, let's say it's an elderly female, like, this is someone's daughter. That person might not be around anymore, but this, wherever they're looking down at their daughter from, like, as a parent, like, this is something they grew up and they had memories. And once again, it is the easiest thing to forget when you're taking care of people because of the technicalities of doing a procedure and doing it correctly and making sure you're ordering the right labs, the right medication. There's a lot that has to be done that has to be very science-driven and objective, but you can't forget the humanistic part of it. So it's just awesome that you were able to say, like, listen, this is the masterpiece that I'm taking care of. And I think it's a view that sometimes is lost too quickly. Okay, so you set the stage for all the siblings to go into medicine. If you don't mind me asking, what do they specialize in? What do they do?
So I have a sister. She is a GI specialist in Texas. I have a brother that is a general surgery resident as well in Texas as well. And then my little sister, she's already married, but she's the little one. She's a second year internal medicine resident in New Jersey.
Wow. Okay. So everyone's really getting it done in their various ways. That must be a very complicated family reunion. You're all arguing about medical topics. I can imagine that's exhausting, but that's awesome to hear that they all went into that kind of, I guess they followed your footsteps. So that means you must have very big footsteps. You worked briefly from 2011 to 2013, I think, as a general practitioner, if I got that right. That must have been interesting. Can you tell me a little bit more about that and how that kind of shaped how you practice now as an OB?
Yeah, of course. So when I was finishing my career as as a general practitioner in Mexico, that's when I found out that there was an opportunity for doctors from outside of the United States to be able to apply for residency here. I did not know that until the very end of my studies in Mexico. So when I knew that, I decided that I wanted to come to the United States for my residency. So what happens in Mexico is when you finish med school, you immediately apply for a specialty as they do here. And most of my friends, that's what they did, and they matched. I decided not to do it because I didn't want to have the temptation of, oh, I'm already a resident here, but I still have the plans to come to the U.S. And I've had met people that had that plan and say, I'm going to just start here in Mexico at residency, and then I'm going to take the steps, and then I'll go to the U.S. It never happened. They stayed there. So I decided to not apply for residency there, and then I started working as a general practitioner in this concept that there's in Mexico, in which like there's a lot of like little drugstores that have like a doctor's office on the side, right? And you charge $1 per consult. And then the business for them is that you send the prescription, or the customer is not, or the patient is not forced to buy the medication from the pharmacy, but most of the patients are gonna buy it from that pharmacy, right? So they will lend you the space with a desk and a chair and a computer, and then in exchange you will just write the prescriptions, and then they will go to fill up their prescription. So I took a job in that type of concept in Mexico, and I learned so many things from that experience because I got to work for the least favored patients in the community. Obviously, people that uses those services are people that don't have any type of insurance, that they don't have a lot of money to go to a specialist, right? And I used to see about 100 patients a day. I will start working at 9 a.m.
That's $100 according to my math.
Mm-hmm.
Wow.
Yeah.
Really?
Yeah.
That's crazy.
Yeah. So I will start at 9 a.m. in the morning, and I will finish at midnight Monday to Sunday. Like I will not take any days off.
That's 15 hours a day, essentially every day of the week, seeing 100 patients. I mean, if you do the math on that, that's roughly what, 7 patients an hour plus, almost
Yes.
8, something
Yep.
like that.
Mm-hmm.
So you're getting like 7 or 8 minutes with each patient. So there better be nothing significant wrong with them because there's
Yes.
not that much time to deal.
And if there is something significant, I had instances in which I had to call an ambulance for babies that were basically dying from pneumonia, things like that. Many of them made it. There was one instance in which the baby didn't make it to the hospital, unfortunately. So people that were very sick, very poor, right? That their resource for a baby that is so sick was going to this doctor's office on the side of a drugstore. Like it was a very eye-opening experience, because even when I tell you that I come from a humble beginning, I was not at that level of need during my childhood, obviously. So when I was working at that pharmacy, I got married right out of med school. My wife is also a physician. She also decided that we both decided that we wanted to come here. So what we will do is she will study for the boards while I worked, and then she took the steps. And then I stopped working for like a couple of months, and she will work in the same type of pharmacy, so I could study and also to pay for the boards, for the tests. And then at the end, I ended up matching first in Pennsylvania, and then she matched after.
That's incredible. I think, it sounds harrowing as an experience goes. I work sometimes long days, sometimes even 15 hours. And I get to the end of one of those and I just feel so drained clinically, emotionally sometimes. It's exhausting.
Yeah.
And it's just amazing that you're able to put those days back to back to back, really to support the patients and then also to support your personal goals and your goals with your family. So that's really commendable at the very least, to say the least. I'm curious, if you have a takeaway from practicing like that for that period of time, if you can kind of give me your one-liner, what's your takeaway from practicing like that? What do you live with today when you think about back then?
Well, I first of all value what I have right now, but I also sometimes feel that patients might not know what they have in this country just by being in the United States. I understand that there's also a lot of challenges here in the United States, but just by crossing the border from Mexico to here, you will have a higher life expectancy. And I think that also has helped me sometimes enlighten patients about how fortunate they are when there are sometimes complaints about things that are not that relevant when you truly have access most of the time to life-saving medicine.
Yeah.
So I think that's what
Yeah.
resonates the most.
Yeah, I think framing is just so significant in life in general, certainly in medicine. Let's say, for example, two people come in, one person comes in and he thinks that the worst thing is going on and he thinks it's going to be a devastating diagnosis. And you say, this actually, it's not so bad. And they'll just be so appreciative because they came in with the frame of mind, this is going to be terrible, projecting what's going to happen, and they'll have a fantastic experience. Meanwhile, someone else comes in with something that they think is relatively insignificant, but you tell them it's maybe not the biggest deal, but slightly bigger deal than they were expecting. And it's devastating because it's such unexpected news, regardless of what it is and the severity of it. And just a lot of life is being able to reframe our experiences and kind of put them relative to other things that could be going on, and recognizing, gratitude is an essential component of, I believe, the Jewish faith, right? So certainly having gratitude in medicine is not insignificant.
Let me tell you just one example of how dire situations can be in Mexico. My mom, being a teacher, she worked for the government, so she had medical coverage through the government, right? But she has had a long history of developing recurrent kidney stones all her life. And they will get to a point that the obstruction will be so severe and so prolonged that her uterus will look like an intestine on an X-ray, right? So to a point that it got to damage her kidneys. But I remember when I was in med school, because I ended up going out of state for med school, when she had one of those instances in which she was very sick. She was being receiving dialysis because of the obstruction, and they told her, you need to have a lithotripsy, but we don't have the equipment here. So
lithotripsy is blasting up the stone.
Blasting up the stone to remove the obstruction of the urine from the kidney to the bladder. So when I was in med school, I was in a city, it was a larger city compared to Chihuahua. So, and I knew, because I was already a student and I was having rotations or rounding in that hospital, that they did have that equipment, and it was the same institution, governmental institution, that my mom had coverage through the government. So what I did is I flew to Chihuahua and I drove my dad's car with my dad with us to the city of Monterrey. We were not able to afford flights for the three of us, so we drove. And it's a 9-hour drive with my mom, like literally having to stop like every hour for her to throw up from the pain that she was feeling, and also from all the toxins from the obstruction, right? So we get to the hospital 9 hours later. They see her in the ED. They see that she comes from Chihuahua when she shows her insurance ID, and they gave her IV Toradol and told her to go back to her hospital in Chihuahua. So we didn't have to pay for private treatment of that. They did have that in our hometown, but it was what will be right now here in the United States like about $1,000. So that was unimaginable for us to be able to afford that. So, and when I lived that with my mom, I told myself I will do everything in my power to never be in this situation myself, and also to be able to help my parents when they get older to have a better life and a better health insurance. So that's also one of the things that marked my life and made helped me make the decision that I wanted, first of all, to be a physician, but also to be as successful as I could be. You know?
Wow. Well, I'm sorry that that's something that you had to go through and that your mother went through. I think my takeaway on that message, I have something similar where sometimes the strongest lessons are through adverse anecdote, right? So something bad, adverse anecdote occurrence, something bad happens and it leaves a lasting impression. Sometimes, once again, all the good things we forget about very quickly. It's the bad things that unfortunately sometimes make a lasting impression. Recently a couple months ago was hospitalized for meningitis.
Oh wow!
Yeah, through Shabbos, Saturday through Tuesday, and it wasn't a comfortable experience. It wasn't enjoyable. It was very tough, even as a physician. So I literally can only imagine what it's like to be a patient who doesn't understand the medical terminology that's going on. But it at the same time, so it was an adverse anecdote. It was a bad event, but at the same time, it was in some ways the biggest reminder of the significance of practicing with care, compassion, humanism. I'm a strong believer that humanism, as the world gets smarter, as the intelligence gets more artificial, the thing that we need to be as a healthcare profession is humans. That's what people are going to rely on us to be. Yeah, I don't mean human with the errors that do occur. Human error is a thing, but human just in the compassionate, humanistic sense. That's going to be some of the most important things that we're going to have to offer patients, I think, in the coming future. So it's terrible that you went through that, but I strongly believe it's those kind of occurrences in our life, unfortunately, that make us on this side of healthcare better clinicians, better physicians. And shifting topic just a little bit, but in a similar vein, so you're coming to Iser as the new director of obstetrics and gynecology, which, it's a tall task. You're ready for it, but it's a tall task just because in a burgeoning community like this, where we work, there is a significant need for people to take care of women in labor, childbearing age, and obviously as they get older for gynecology needs as well. That being said, I do remember as a third year my OB rotation, and I thought for about a single day that I wanted to be an OB-GYN, and the second day of the rotation I realized I didn't want to be an actual obstetrician or gynecologist, someone who takes care of women's health. So I'm just curious, as a male, right, what was your impetus to go into the field? And then I'll have some follow-up questions on how you navigate the field.
Okay. Yeah, so again, I grew very close to my mom. Obviously, I have both my parents there together, and I love my dad, but, sometimes, especially being the eldest, my dad used to work long hours, and my sister is 5 years younger than me, so I spent the first 5 years with my mom every single day, and I saw that in many instances, healthcare for women is still a challenge, and the quality of care for women specifically still has a lot of room for improvement anywhere in the world. I don't know the reason why. But I see it now as a gynecologist. You go, and I have had the opportunity to go to shadow or run with cardiologists, cardiothoracic surgeons, and the amount of technology that is available for these specialties is unbelievable. But you go to OBGYN, and we still have instruments that were created like Forceps, which are great and I love to use, but were created hundreds of years ago, and that's basically just an example. Okay, there's also robotic surgery right now that I also love and I do, but it is not especially designed for women's health. So I see a lot of need for innovation and attention to the needs of women. In terms of my decision to be a gynecologist, I happened to be born with forceps, and it was a difficult labor for my mom, and also was a dangerous situation for me, based on what she tells me, that it was a dire situation in which if she had not had a skilled obstetrician at the time of delivery that was able to deliver me expeditiously with forceps, probably I will not be here. Actually, he used to call me the little miracle.
Oh, wow.
So that also had a lot of impact on me choosing the profession, the specialty that I have right now.
That's an awesome. So we should call you the Miracle Child. Is that what we're gonna? I mean, we gotta figure out nicknames.
That's how he used to call me, like the obstetrician.
Okay.
Because when she will go to her gynecologist appointments, not for pregnancy necessarily, she will take me with her, and
Right.
then he will call me that.
You might be Dr. Miracle after the podcast is launched. I mean, you can't control how these things get put out there. So, but that's obviously our life experiences impact our professional decisions. Certainly, as physicians, when you go into a field that's so passion driven, it's rare that you find, if I'd ask you a question, you're like, I don't know, I just threw a coin up in the air, landed on OB-GYN. There's generally, I find a very nice, heartwarming story behind how people chose their specialty. For me personally, I did emergency medicine because I was an EMT and I got to see people at their most vulnerable in their homes. And I just felt like knowing a bit about everything, even though I had 120 clinical hours of knowledge as an EMT, but I just like that idea of being able to help people in an emergent situation with almost any complaint. And then, obviously after 5 or 10 minutes, we get the specialists involved in the real dire situations, hopefully. But yeah, it's very cool. Now, how this is one of the reasons why I didn't strictly go into OB-gynecology. Of course, as an ER doctor and acute care urgent care doctor, I deal with sensitive issues. And I recognize that I'm also a male dealing with sensitive female issues at times. What is your technique, or do you have a technique to really engage in a very trusting and comforting way with the patients that you see? Because obviously it can be tough, especially if there's community sensitivities. How do you make someone feel comfortable?
Yeah, and I will go back to a comment that you made at the beginning of the interview about the humanity of the treatment to patients, and seeing the person that you have in front of you is God's creation. But something that I really mean, and I say it to all my patients when I find that difficult for them to accept my care because of my gender, or because they are in a stressful situation and it's hard for them to understand what's being offered to them, is I know that you probably are not in the right state of mind right now, especially in an acute situation, to make the best decision about your care. I'm giving you the options, and I think that you're choosing probably not the best option, and I will not force any treatments on you, but I just want you to know that the way I practice, and I mean it, is I see and try to see every patient as if they were my family. Like, if you were my sister, if you were my mom, this is what I will do for you. This is what I will offer you as the best choice of treatment. And I've never had a single instance in which, when you say it and they see it in your face, that you mean it, that they are not gonna accept the treatment, or not the treatment option necessarily, but also being seen by you as a male. I always try to make patients feel comfortable with my presence, and also I've had instances in which they say, if there's a female provider, I will prefer that. It's completely understandable, and we will try always to accommodate for that if at all possible. But most of the time, I've been very successful establishing a great relationship with my patients, and they trust me, and I am very proud of that.
Yeah, I think that's spot on. Let's say, for example, when I see a pediatric patient, in an urgent care setting, right? And they come in with maybe borderline vitals, slightly febrile, slightly tachycardic, some abdominal pain, but it's very non-specific. And their exam is, let's say, overall reassuring. The vitals aren't perfect. There's a lot of diagnostic uncertainty. I don't know what's going on, and I have to make a decision. Well, I don't know what's going on yet. And I think time will declare what really is, going on in this particular case. Can this patient go home, or do they have to go to the hospital, right? And in my head, there's a conundrum. It's like I'm not sure what the best thing to do with this patient is, and I find that oftentimes, frank shared decision making about what I know, what I don't know, what the trajectory could look like in a couple of different ways, and saying, do you feel comfortable monitoring your child at home, and just being aware that if the belly pain gets worse, if they start vomiting, if the pain migrates from around the belly button to the right lower side, this could be early appendicitis, and I just didn't see it today, or I didn't see it right now, and if they're comfortable with that and they're receptive, I'd be like, okay, well, that's what I would do with my daughter. I would keep watching her at home until I thought, I really think at this point it's unsafe, and if there are some people who are uncomfortable with that uncertainty, well, then you got to take a ride and get it checked out now. But just having the ability to be open with your patients. And, I think the other thing you touched on there is a couple components of, the pillars of medicine, which is paternalism and patient autonomy, right? Being paternalistic means to be a parent to someone, to tell them what they should decide, right? And patient autonomy is generally, in frank contradistinction, is completely opposite to that, right? Where it's, well, I can make my own decisions about my body, which we agree in the medical setting that is the case. And sometimes those two butt head when you really feel like something is the correct medical treatment and they really don't want to do that thing. And trying to negotiate that, it's an art. It is not easy, but I do agree with what you said. I think the art gets easier if you can see people as humans, because not only is it easier for you, it's easier for them to be receptive of the care that you're giving them. Because, and just going back to my personal experience when I had meningitis and was in the hospital, when the doctors came in, and there were some excellent doctors, there were some excellent nurses and techs, and I wish I remembered their names because they deserve shout outs. But when the doctor came in, and I said this to people, I said, when I felt the empathy, when I felt the humanism, I was on board. When they came in, and it felt so, I'm checking a box right now. I got to go in this room and out of this room. There's nothing for me to really do. I don't really need to talk about anything, and even if they tried feigning the empathy, you just saw through it. And I was more comforted as a patient, and I was more likely to listen when I just felt that humanity. So I think that's spot on. Is there anything that is in the field of OB-GYN that you're kind of like excited about? Meaning, maybe you said robotic surgery earlier, because a lot of the tools you mentioned are kind of feel outdated. Is there anything that you just feel like we're at the cusps of in the field that, you fast forward 5-10 years and it's going to make a drastic impact on women's health?
So I personally have a passion for innovation. So I'm pretty sure a lot of new technologies that are in the works right now that we might not even have knowledge of. But personally, I have taken upon me to bring something to the field that I might be remembered by, and I've been working on innovation projects for several years since I was a resident now, and I've filed for several provisional patents on different products. There is one that I am very excited about that I've been developing. I'm now in the third iteration of these devices, which is completely different to the first one. Just trying to find the best product, the most cost-effective approach for evidence-based interventions that are interventions but don't have a product specifically designed for it. So I think that is one of the main things that keeps me up at night, not because I'm worried about it, but because I am so excited about it. Like I'm always thinking, okay, how can I improve this? What needs to be tweaked? And I have several prototypes that are working already, but I'm trying to define which is going to be the final iteration that we are ready to launch. So I don't know if that answers your question, though.
It does, in the most vague sense. It answers my question. But no, I think no. Listen, I think that's awesome, and obviously wish you the best of luck. And I hope it helps women. I hope it helps women's health, universally, nationally. I've thought about in emergency medicine. I think this is the problem with people in the medical field, that we literally don't put down work in our brain for the most part. Even if we've stopped physically working or clinically seeing patients, there's some thought that follows it. My program director in residency, he used to say all the time when I was a resident in emergency medicine, that you need to be thinking about airway management while you're driving in your car, right? You're driving in your car. We're not talking about music. We're not talking about enjoyable You think about how you're going to manage a very difficult airway, because that's your job as an emergency physician. I literally, as I'm driving a car, think about airway management a lot of times. What I would do, my algorithm, which is, it feels like a sickness, but honestly, I know it's good for patient care. But yeah, I thought about an idea for a device, and I really was like playing around with the idea. I was like, this would be so beneficial for a tough airway. And I started doing some research. It's actually been invented already, just it's hardly used. So I said, oh, this is a much harder project than I thought it was. So I put it to rest. But it's good to hear that you're putting things together. I kind of, just for other general knowledge purposes, I think it might be beneficial. I imagine someone who is going to their first gynecology OB visit, right? I don't know how young when they generally start going for this thing. I imagine it's extraordinarily anxiety provoking. How do you deal with that?
Well, if it's an obstetrical patient that comes in because she found that she's recently pregnant, the first thing that I say when I go into a room is congratulations, because from my perspective, being able to have created life, it's a blessing, and most of the time that is something that patients find a little bit, I will say, unexpected, because they are anxious about it. Like many times, especially generally speaking, in the United States, more than 50% of pregnancies are not planned, right? So there's a lot of anxiety around it. But when you congratulate them on that, that might soothe the mood a little bit for them. And then I immediately start asking, how are you feeling? Are you having any nausea? Many patients are miserable at that time, Mm-hmm. And I address what I think are the main things that a patient at that stage are gonna be going through, emotionally speaking, by congratulating them, and then physically speaking, like many patients have not been able to keep food down for the last couple of days before they saw you. And that's usually the way that I start a visit for an obstetrical patient. And they start opening up, and then the next stage will be in the same visit asking, what concerns do you have? What questions do you have? And that is very conducive for the patients to start developing a relationship with you from the very beginning, if you are the first doctor they've seen for the pregnancy, or if they have not met you before for a gynecologic visit. In terms of a gynecologic visit, it can be very variable depending on if this is an annual exam versus a problem visit. When it's an annual exam, patients tend to be more relaxed because they know that they're just there to make sure that everything is fine. But when I find it more interesting and also challenging, but at the same time motivating for me as a physician, is when they are looking help or seeking help for a problem that they're having, and it's been very rewarding to grow as a physician as well, from the time that I graduated residency till now, to being able to develop your own style. When you are a resident, you are learning from lots of different doctors, and then you are taught many ways of doing the same thing, different ways of doing it. And when you first come out of residency, you have to find how you're gonna practice medicine. And I think that at this point, I developed what I feel is the style that I wanna be as a doctor, and the most important thing for me, as we have been mentioning, is being humanitarian or humanist in the way that you approach people. And I mean, there's a lot of good doctors in this world, but I've seen a lot of them that are not great at treating patients in terms of not the medical condition, but the rapport that they develop with them. And it's a shame because you sometimes see this eminence, like the best in their field, but they don't even look the patient to the eye, and that's not how I want to practice. So what I can tell whomever is listening to this podcast is I always do my best to, whenever you enter the room and we met for the first time, to show you that I really care about each one of my patients, because again, I try to see them as family, and that is what motivates me to keep doing what I do.
So I'm going to teach you something here because you're with a new community, so you're going to have to learn a little bit of the lingo, all right?
Mm-hmm.
So when someone's expecting, the thing that you tell them instead of congratulations when you walk in is it's going to be a Hebrew phrase, and it's Bisha Tova.
Bisha Tova.
Very good. Bit instead of vid, but otherwise great. And that means it should be in the right time. So it's the way it is saying that, it's congratulations, but, there's a long road ahead of you, and there's a lot of things that can happen, and it's early, late, on time. But whatever it is, it should be at the right time. Yoki, how do you pronounce that better than I said it? B'shu toiva mitzlachas. Okay, that's why I had to call in the professional for that. But yeah, even if you say b'sha tova, I think they'll get it. But if you want to throw in the twang, I think it'll come out a little bit nicer the way Yoki said it. But
I'm gonna have to practice it a couple of times before I feel ready.
Well, thank you. Don't worry, you'll bounce it off me, and you'll listen to the podcast and play it back a couple times. So but the other thing I take away is two things. I only take away two things. Every time I say it, I take away two things because my head can't fit three things, so it's two things. But no, the first thing is the art of medicine. Like you were saying, you come out and you practice, and you've got to figure out how you do it. The benefit, I remember in emergency medicine, watching all of my different attendings and taking different things from them, things that I liked and things that I didn't like, and that I'm an amalgamation, I believe that's a word. I'm a composite of all of those different character traits that I wanted to see, and then I try and make sure that I'm pushing out the ones that I didn't like so much. And that's how I practice the art of medicine beyond just the science of medicine. And to your point about making patients comfortable and how you do it, like I always try and judge the encounter, and especially when I'm seeing an older patient. My MAs know this at this point, so it's actually kind of funny. They'll like kick out the stool towards me because they know immediately when they walk in the room to help scribe with me, it's a sitting encounter. I'm going to sit here. I'm going to try and get face-to-face and communicate because, and once again, going back to when I was a patient, I remember just laying in the bed, and I think one of the doctors sat down next to the bedside and was talking to me, and how much of a relief that felt versus doctors when they would stand over the bedside and talk down onto me. Even I am a doctor too, but at the time it feels very demeaning. Maybe demeaning is not the right word, but it feels overpowering, maybe is a better way of saying it. You feel very secluded and very minimized in that kind of setting. So when you sit and you kind of look at someone face to face and you have a collegiate, friendly conversation, once again, it makes people trust you more. And the reason we want them to trust us more is so that we can give the best possible healthcare. If someone doesn't trust you, I've said it, I don't know, this is the fourth or fifth time in the podcast. So at this time, maybe everyone who's listening, which could be three people, I don't know, but they're going to be saying it with me because I've said it so many times. But no one cares how much you know until they know how much you care. And I've attributed that quote, I think it was Teddy Roosevelt. Who knows if that's correct or not? But that's the truth, that you could be the smartest doctor, like you said, a very preeminent physician, a very important individual. If you can't connect with someone through the correct eye contact and just showing empathy through your body, all the nonverbal cues, it doesn't really matter how smart you are. No one's going to buy into your treatment plan. And I remember talking to my wife after the hospital stay, and I said, 2 doctors said the same thing. It felt completely different coming from each of them just because of all these nonverbal cues that I can't even possibly, I do this every day, and I can't even tell you what the nonverbal cues are, but I know that they were there because it changed how I felt about the encounters. Speaking of innovation, I don't know if this is something you want to talk about, but there was something I noted that was interesting on your resume, that because surgery, you do a lot, gynecology, a lot of laparoscopic surgery, insufflate, put air into the abdomen, and do things with small little trocar, small little holes in the abdomen, so it's minimally invasive, as reasonably as possible. This is a non-surgeon. Don't listen to what I'm saying. This is what I remember from my medical school education. But there was always an issue where you use a camera internally and it keeps fogging up. So you had something about trying to defog the camera. I don't know if that's something that you can talk about, want to talk about.
Yeah, we can. Yeah, so when we were in residency, me and another colleague, my senior resident, decided to develop this simulator of the abdominal cavity that will have the humidity of the abdominal cavity, and we will make it dark so the light of the camera was the only source of light inside that box. And then we tested different defogging mechanisms that are already known in the literature, but they were never compared to each other to see which one was the most effective. Some of them are products that are sold by different companies, but some of them are just interventions such as immersing the camera in warm saline before putting it inside the abdominal cavity. And it was very fun, first of all. And we found out that the one that is the least expensive is the one that was more effective, which is just saline, warm saline, submerging the camera in it before putting it inside the human body. Will have the least amount of fogging. And the paper got accepted, and it was something that was very interesting. We presented it at the Minimal Invasive Gynecologic Surgery Symposium that happens every year from the American Association of Gynecologic Laparoscopy. At that time, that year was in Washington, D.C. So we went to present that project, and it was very successful.
You're a real underachiever, you know that? No, I like that story. I like that story because the best way to connect with patients is by giving them a cheap alternative for how to get something done in medicine. Perfect example is all these over-the-counter cough medications. There are some that are prescribed by clinicians even, and this is my understanding of the evidence. I remember learning this in residency, especially in pediatric emergency medicine, precluding patients, not including patients under a year or maybe 2 years old because of the risk, but honey is the best medication for coughs. It's the best natural cough suppressant that there is. Wow. You can do cough drops with honey, you can do tea with honey, whatever it is a natural, cheap, cough suppressant, so to speak. And it works just as well, if not better, than all the other things that are sold. And it feels good because every once in a while when you're able to tell a patient a true, authentic, natural way of remedying their symptoms, I just feel like it gains trust because, if every time someone came to me, I was like, oh, buy this medication, at some point it's like, is this guy just trying to sell me all the medications in the world, right? But yeah. if they can come to me with a symptom and I say either you don't need anything, just give it time, or a little bit of honey, any brand you want, no big deal, watch out for the age depending on how old, and it'll help you out with the symptoms. It just feels, once again, I think it appeals to people's natural instincts, but also no longer does the physician just feel like a perpetual drug peddler where I'm always giving you something to solve your problem that, is in a pill or a capsule form. So it's nice when it's an inexpensive solution to a common problem, not an expensive solution to it. One other thing that I want to talk about briefly about your background, then we'll kind of move on to the second segment here, is there was an interesting case report about an 18-year-old male who had collapsed lungs on both sides, and this was spontaneous. I don't know if you still remember the case because it's not necessarily recent, but it just caught my eye. I didn't know if you wanted to talk about it.
Yeah, so that's a case that we saw when I was in Mexico doing my social service. So when you finish med school in Mexico, even if you go to a private school, I went to a private school, but without a scholarship, I must say, but it was a private school. So when you finished your med school, the government says that because they paid for your education, you have to give them back 1 year of medical practice for free, basically, right? So we are assigned to rural areas or underserved areas, and I worked in the state of Zacatecas in a hospital. And then we had this kid that came in collapsed. That he was basically just like fine at school, and then all of a sudden he started getting short of breath and getting like blue and cyanotic, and he was rushed to the hospital. And he immediately got an X-ray, and then we saw that both lungs had spontaneously collapsed, and he had a bilateral pneumothorax. So it was a very interesting case. He was able to be treated in a quick fashion, and he did well. But we reviewed the literature, and it seemed that there were not a lot of cases reported on this, especially being spontaneous, right? So we decided to prepare this case report, and it got accepted in Critical Care and Shock. It's an acute care journal that is actually supervised by Dr. Joseph Veron, which is intensivist in Houston. I went to Houston for my internship, and that's where I met him. And then after I came back from Houston and I went for my social service, I sent him the paper, and then he said, this is great for the journal. So he helped me get it published.
That's really cool.
Yeah.
I mean, I hope the child did well.
He did well.
He did great.
He did
Okay,
great.
great.
Yeah.
Great ending. Those are the best stories, the ones that have great endings. But
Yeah.
It's also, you can see it in trauma, certainly, theoretically, that both the lungs can collapse from a traumatic experience. Once again, theoretically, it's spontaneously unilateral on one side. You can have a collapsed lung. I mean, like you said, I've never even heard of both of them collapsing, and obviously that's as life-threatening a situation as you can imagine is both of someone's lungs being down and not functional. So that's a great save. I'm happy to hear that. That's really cool. Being someone as an emergency physician, putting these, when someone has a collapsed lung, they get a tube in their chest, varying sizes. As we've gone more and more advanced, we tend to put smaller and smaller tubes in the chest to cause as little iatrogenic or hospital-caused trauma as we need to cause. So it's definitely advanced over time. But those are the very I don't want to call it exciting. It's not exciting, but certainly when the adrenaline is pumping and the team is really galvanized to work together to solve it as quick as possible, because time is of the essence. I mean, in your case like that, I mean, I'm glad that he had a great outcome, because that's a pretty wild case.
Yeah.
Switching topics a little bit. I think this podcast maybe isn't the place for us to delve deep into obstetrics or gynecology. So I had to think about, but I didn't want to it's your field of expertise. So I do want to give, maybe the audience a little bit of a primer, people who aren't so familiar with something about the field. I want them to be able to walk away with a good idea of a part of OB or gynecology. So I decided on maybe like traveling with you through a pregnancy very quickly. This is not going to be the normal 9 to 10 month affair that an actual pregnancy is. We're just going to sweep through it in a half hour or so, which doesn't give enough credit to what it is. But, I just, as a primer, I think there's some value there. And also I thought, well, what's the best way to do it? Let's just do this. Let's use a timeline. Let's start from the very beginning and we'll work our way to the end, right?
Yeah,
so starting off, with pregnancy, I think that, and I'm going to tread lightly as an individual who's never been pregnant once in my life, discussing the topic, and I want to give it the sensitivity that it deserves. I think when people become pregnant, or even before they become pregnant, the first conversation that needs to be had is probably about prenatals. And I can imagine, it tends to be tough for people. This is the worst pun, a tough pill to swallow. It's a tough pill to swallow, that someone has to take a medication daily in life in general, whatever that medication is. But I think if people know the value of taking the medication or the supplement or the vitamin in this particular case, I think it becomes easier from a compliance standpoint to get people excited. Maybe not excited is the right word. Once again, I'm treading lightly. I've never been pregnant. But to get people motivated and to really understand why they're doing it. So what is the reason that that gynecologists recommend taking prenatals. How long does a woman have to take a prenatal before she's planning on getting pregnant, taking it throughout the pregnancy, taking it after the pregnancy? If you can just give us a quick primer on that.
Yeah, so very good point. So if we have a person that is trying to get pregnant, ideally the patient should start taking prenatal vitamins at least 3 months before they conceive. And the main reason for this is because we want to build up the folic acid levels in the patient's system, because it's the way that we can decrease the chance of developing a malformation on the baby that's called spina bifida. So the folic acid that these vitamins contain is well known to decrease the risk for this malformation that can be devastating, because if it were to happen, then the spine is damaged, and it will cause the baby to sometimes lose mobility of the lower extremity of the legs. So if a patient is actively trying, that is one of the main benefits. So vitamin D in general also has been found to decrease the risk for preeclampsia. So sometimes we can actually add a little bit of extra vitamin D on top of the prenatal vitamins. If there is a safe dose that is recommended by the American College of Obstetrics for vitamin D. So it's important to note that higher doses of vitamin D could cause problems in pregnant patients. But we would discuss this with the patient at that time if she has a higher risk for preeclampsia, depending on her risk factors, or if she does have a history of having had preeclampsia in the past, she might benefit from vitamin D. So not everyone needs to take additional vitamin D, but at least for the prenatal vitamins, folic acid is paramount to decrease the risk for this. And as you mentioned also, given that the first weeks of pregnancy is when the baby is forming, is more important. So the first 14 weeks of pregnancy is when the baby is being formed. After 14 weeks, the baby is completely formed, either satisfactorily or with a malformation, right? So, and unfortunately, it's when the patients have the most nausea. So we see a lot of patients saying, yeah, I know that I have to take my prenatal vitamins, but when I take them, I just throw them up, right away I have a vomiting episode. So what I found sometimes is that if the patient cannot keep down the whole prenatal vitamin, it's better to sometimes try the folic acid only, because it's a way smaller tablet, and that is the one that has the most data behind it. So if you can take the whole prenatal, it's great. But if for some reason the patient is so nauseous that she's not being able to keep it down, we can either try gummies. Sometimes prenatal gummies are better tolerated than the tablet. And if they don't tolerate the gummies, then we can sometimes try just the folic acid.
Now, I guess a follow-up on that is that I feel like maybe some of the confusion is, there's, I think, 400 milligrams. I don't know the dosage, once again. Not a gynecologist, and also not a female who's taking them, and there's like 800, there's different dosages for them. And there's also, if you walk into any like pharmacy, it feels like there's a wall of varying brands and dosages. And I just feel like I'm getting dizzy looking at them. And I feel like that could be a source of confusion. Is there any way to like simplify it for people so that it's, once again, there's a medical disclaimer before this podcast, everyone should seek care from a qualified physician and get their specific recommendations. But in generalities, is there any difference between the two? Who should take what, once again, in the most general terms?
Yeah, and that is a great question too, because I am sad to see that how the pharmaceutical companies make a fortune from these supplements, right? And then you can find prenatal vitamins that are $30 a bottle when like the most inexpensive is like probably like $4 or $5, and they are all FDA regulated in the amounts that they are that they need to contain to be called prenatal vitamins. So, but just because they add a little bit of more iron, which is negligible, and it's basically not gonna get absorbed, they triple the price. So I always tell my patients, just buy the least expensive prenatal vitamin that you feel that you can keep down. So you can go. I can prescribe you a specific one, or you can go to the drugstore, go to the prenatal vitamin section, and find the cheapest one that you can tolerate. That is surprising to many patients because they really feel that I might get the most expensive one. And there's really not a lot of data that says that because it has a little bit more iron, it's just marketing. So the short answer is the cheapest prenatal vitamins that you can take and keep down.
It's awesome.
Yeah.
I love that because just once again, in medicine, first of all, there are unfortunately things that cost a tremendous amount of money, and there are good reasons why some things cost a lot of money. And I think there's probably a natural bias. Something costs a lot of money. People assume it must be great, and that's not necessarily true. And I think that we validate ourselves as clinicians when we're able to go these cheap routes that are just as effective and save the patient's money. I always say like this, money is a zero-sum game. Literally, you have it or you don't have it. And if you spend your money doing activity A or on medication A, you can't spend it doing activity or medication B, which may be more vital for one's health or one's lifestyle. And we're the ones seeing the patients. The pharmaceutical company is not seeing the patient. They can decide whatever they want within reason, I guess, or maybe not. Once again, I'm not part of the FDA. I don't do pharmaceuticals, but they can charge a tremendous amount of money for something that essentially it could be a quarter of the price that someone else can provide you the same exact content, but it doesn't have the glitz or the glamour of that other company. And once again, it preys on the fact that patients will assume the $90 drug is better than the $20 drug, and that's not always the case. Probably something that deserves a shout out in this podcast, I haven't mentioned it before, is there's an app called GoodRx. I don't know if you've heard of it, used it, but I think, I don't know how they make money or what they do exactly to do that, and how they're able to do this rather. But they're able to give patients an understanding of the local pharmacies and where to get the medication the cheapest. And the reason I'll give them a shout out on this podcast is because, once again, the thing that is going to be the best by the patient is the thing that should be valued at the highest. And if you're not the clinician taking care of the patient, sometimes the priorities are different, right? Pharmaceutical companies' priorities is to ensure that they have the best profits and shareholders and that kind of thing. And the clinician's priority, a good clinician, is like, I want to do the best thing by you, but I also want to save you money. I don't want you spending I'll give you another example for that is in my world, if someone has a bad otitis externa, a bad outer ear infection, sometimes you want to give them a little bit of a steroid, you want to give them a little bit of an antibiotic. There's a medication that goes by, I don't know if this is the trade name, but there's a medication that combines an antibiotic and a steroid. I've heard from many people that if you give this joint medication, some insurances, it's hundreds of dollars for them to pay for this medication. If you give the two medications separately in a different way, they could be spending $10, $20, and that's a massive difference, especially when you're talking about working in a potentially an underserved community or an economically suppressed community that, why should they get a worse medication because they can't afford, who should be able to afford a $300 drug? But, they should get just as quality an option and care. And they shouldn't be, once again, you shouldn't say like, sorry, this costs $300. I can't do anything else for you. Right? So it's awesome to be able to have these, low cost options for patients that are just as good as other costs, as other medications rather. Moving on in pregnancy, so someone's, let's say, 6 to 8 weeks, right? Once again, everyone should go get their general advice from their general physician. But let's say a woman has, is 8 or 9 weeks pregnant. She starts having abdominal pain, maybe even some vaginal bleeding. What, in general, what should be their next steps in that case?
Yeah, so what we will recommend is to seek medical attention, but depending on how brisk the bleeding is, it will be the acuity of the attention. So if it's spotting, I would recommend they call the doctor's office and let them know what's going on, and then the provider will determine if the patient needs to be seen the same day, or if they want to do some blood work to see what her pregnancy hormone is, and order a sonogram. If the bleeding is brisk, then patients sometimes might need to be evaluated in the emergency department to make sure that they are not unstable from the amount of bleeding. There can be different reasons why a patient bleeds in the first trimester. Sometimes it could be as simple as what we call implantation bleed, which is when the baby's getting attached to the uterus, the placenta kind of like erodes the wall of the lining of the uterus, and that could cause a little bit of bleeding. But sometimes it could be a sign of a threatened abortion.
And threatened abortion is essentially, in colloquial terms, a miscarriage. I think that's what people
it
generally...
could be not a miscarriage itself. It could indicate that you could be having a miscarriage,
Right.
because patients with a threatened abortion sometimes might continue to have a successful pregnancy. But in the first trimester, regardless, even if there's no symptoms, we recommend doing a transvaginal sonogram to determine the weeks of the pregnancy. But if the patient is bleeding, then that sonogram might need to happen sooner than expected. First of all, to determine if there is a viable baby that we can see in the uterus, or we can sometimes say, oh, it's too early, we don't see anything, but that doesn't mean necessarily that there's something wrong. We might need to give it a little bit more time. And in that scenario, usually having the pregnancy hormone level is very useful, because usually we need it to be at least 3,000 for us to expect to see something inside the uterus. If it's less than that, then we cannot say that this is an abnormal pregnancy. It just might be too early.
Yeah. I mean, that's, first trimester vaginal bleeding is something near and dear to my emergency medicine heart, because it's something that we don't infrequently see in the emergency room. And, it's those are some tougher encounters, because generally speaking, it's at night, because in the morning time, they're able to get their appointments with their obstetrician, their gynecologist, so they're with a familiar face in a comfortable environment. And at night, the nighttime's a scary time to begin with, and they're in a foreign hospital. Maybe they haven't been in that emergency room before. There was so much tentative excitement about this pregnancy, and now there's worry and concern. And it can be a very stressful time. And from an ER standpoint, we're doing the basic blood work usually, making sure they're not bleeding too much with the CBC, maybe checking electrolytes, kidney function, that kind of stuff. And then we'll oftentimes, if we can't see anything, draw the beta-quant, that pregnancy hormone that you were speaking about. And we have a sense, we do a transabdominal ultrasound if there's availability or the capacity, a transvaginal one, to see if we can see the early signs of pregnancy. But it can be a harrowing moment. It can be very tough for family, especially if there's difficult news based off of the evaluation. But once again, those to me are the clinical encounters where we're needed the most, right? For the average minor encounter, I don't remember who said this, but someone said, God forbid, let's say that person ends up losing that fetus, that baby in utero. They always remember it. Women always remember, like, they have a certain amount of kids, but they also know how many miscarriages that they've had, because those matter to them, because at the time, that those were dreams and expectations that didn't come to fruition. So, it's a time for me to pull up a chair and have a conversation and say, this just happens, and this is not your fault. And sometimes it's the genetics were not strong enough for the pregnancy to hold, and once again, it's framework. And if you frame it the correct way, you can give someone at least an early sense of peace and solace. And at the same time, if you do it wrong, you can absolutely destroy someone, right? If you don't show that humanism and the emotion and compassion, and you look very rushed and you are very rushed, you do a cursory, very quick exam and quick evaluation and very bluntly say what's going on without care and compassion. I mean, I cannot imagine what that does to a woman and to her spouse at bedside too. When they get the news in not the most professional way. So those are the moments where you got to stand up and shine, right? So I appreciate your insight on what women should do in that case. Ectopic pregnancy, what exactly is it, and what does one have to do if it's something that they unfortunately would find out that they have?
Okay, yeah, so an ectopic pregnancy, by definition, is a pregnancy that is located outside the uterus. And it can be in different locations, but the most common one is a fallopian tube. It can also sometimes be in an ovary, although it's very rare, or sometimes even in the abdominal cavity, right? So when an ectopic pregnancy is identified with a sonogram, We need to counsel the patients that unfortunately will not be a viable pregnancy that we can continue to follow, because we will be putting the patient at risk of life-threatening complications. Most of the time, if you have an ectopic pregnancy and you know about it and you don't do anything about it, it would cause an acute abdomen from bleeding. It tends to cause damage to the structure in which it is located. Most of the time, as I'm saying, the tube, it can get to a point in which it ruptures and then starts bleeding heavily. And unfortunately, I've seen cases in which patients can have a large amount of blood in their abdomen, and get to a hospital very unstable. So depending on the size of that ectopic pregnancy, the amount of the pregnancy hormone, there are two main options for management. One can be medical with methotrexate, which is a medication that destroys the pregnancy without the need for surgery. But we have certain criteria that we need to follow to make sure that the patient is a good candidate for it. If the pregnancy is too big in the sonogram, more than 5 centimeters, or if the pregnancy hormone is more than 5,000, then the likelihood of or the risk for failure with medical treatment is higher. So it's not something that cannot be discussed, and some patients, as long as they understand that there's a higher risk for failure or a need for additional doses of methotrexate, they could choose that as long as there's no signs of active bleeding and unstable vital signs. But usually that's the cutoff. If it's larger than that, or if the patient is acutely bleeding, then the best management will be surgical. And we always try the laparoscopic approach, which is the one that you mentioned, with small incisions and a camera. Sometimes it might be necessary to make a larger incision if there is visibility issues from the amount of blood or things like that. But in my experience, always, most of the time, I've been able to complete a surgical treatment with laparoscopic approach.
Yeah, I mean, I think that the terminology ectopic pregnancy, it kind of is misleading in some ways, because there are women who I imagine would believe like this is a pregnancy like every other pregnancy, and I don't want to lose this baby, right? Yeah. And the reality is the baby is not in any way, shape, or form in an area where it can grow and be nurtured, and 9 to 10 months later come out as a fully formed fetus ready to enter this world. It is in a, like you said, the uterus is the house for the baby, and it could be in the little tube that's outside of that house. And if it gets too big in that tube would, pop open, so to speak, and the bleeding, and it's extraordinarily dangerous. It's in no way or shape or form not a viable pregnancy. So like the term ectopic pregnancy, especially because we sometimes use all these very convoluted sounding terms, I think that sometimes it can be misconstrued of I don't want to lose the baby, but there's no you're not capable of maintaining that pregnancy, and it's really a life-threatening condition. And certainly I've seen in the emergency room setting that people can bleed a tremendous amount into the abdomen, and that was, we did the exam and that was the cause. They have a positive urine pregnancy test, and there's blood in the belly. They thought they were pregnant, but unfortunately it was an ectopic pregnancy, and the blood pressure could be very low. There's no scarier moment than a young, otherwise should be healthy individual who is extraordinarily ill. Maybe some would say even at death's door in the emergency department. Those are the cases where everyone pulls together, and there's certain heightened level of job performance and expectation, because we care about everyone that we take care of, but those just humanistically get to you a little bit more. The younger the patient is, it's just kind of a natural knee-jerk instinct, I guess. But okay, moving on, second trimester checkups, right? Mm-hmm. I feel like the first trimester, there's a lot of uncertainty. There's a lot of the ultrasound, the beta evaluation. Is the pregnancy in the uterus in the correct place? Is there one pregnancy there? Are there multiple, right? And then I guess you get a sense. And then the second trimester kind of goes along, and maybe there's a formal 20-week ultrasound or something like that. But what is the significance of that second trimester of the checkups? What are there genetic tests that are performed? What is, what does the second trimester look like for most individuals?
Yeah, so First of all, once a patient reaches 14 weeks, that's when we call the patient to be in the second trimester. The risk for a miscarriage decreases significantly. It's not zero, but it's way less. So we always tell the patients when they reach the 14 weeks, congratulations. The risk of losing this pregnancy is way less right now. By that time, we already
You're gonna have to work on Bashat Tova.
So, and by that time, we already did the initial prenatal blood work that checks for different conditions, anemia, any sexually transmitted conditions. We also check blood type for the patient that is important later in the pregnancy or in the case of bleeding. And we also usually offer genetic screening for the baby in the first trimester. And the one that is most commonly used nowadays is the non-invasive prenatal testing that can determine via a blood test from mom's arm without the need for any invasive needles on the mom's abdomen for the baby. It can check the chromosomes of the baby running through mom's veins, which is pretty amazing. And it can also, if patient desires, offer the gender of the baby. So that's usually optional, and the genetic screening is not something patients must do. It's something that we offer the patients. For the non-invasive prenatal testing, or NIPT, it can be done as early as 9 weeks, but it can be done all the way throughout the pregnancy. So now that we are in the second trimester, though, the goal is to take a look at the baby's anatomy via a sonogram, and this sonogram doesn't need to be transvaginal anymore, because now the baby is big enough that we can see most anatomical structures on the baby with a probe on mom's abdomen. And it's a very beautiful sonogram. It's a long sonogram, actually. It takes about 30 to 40 minutes. And the intention and the purpose of this is to check the baby's anatomy from head to toe, just to make sure that everything looks fine, that there is no signs of any abnormalities or malformations. And this is very relevant because if a patient is found to have an anatomic malformation, then these babies might need to be born at a higher level hospital. So some patients might want sometimes decline the sonogram because they don't see the value of it, seeing that no matter what the sonogram shows, I'm keeping this pregnancy, and we understand that, but we want to know if you need to go to a higher level hospital to have this baby, if the baby were to be born with a condition that needs immediate attention, like cardiac malformations or things like that. So there's a lot of value in it because it allows us to prepare in the case that we see that the baby might have something that needs a higher level of treatment.
Yeah, I think ultrasounds, and once again, relating back between our fields, not that there's not a lot of disagreement between OB and emergency medicine. I guarantee you there is a tremendous amount of that, and we can get into that in a later episode. I'm sure we will. But there's obviously a lot of symmetry and a lot of agreement overall. A lot of synergy. We work together pretty well a lot of the time. But with ultrasounds, there's like this duality there, right? So there's some of it we're doing for us and some of it we're doing for them. So it's, if I have a patient who happens to be pregnant and I'm evaluating transabdominally with an ultrasound, I need to know the basics. I need to know is there fetal movement, what the fetal heart rate looks like, general age, either, the BPD or the yolk sac size or the crown rump length. Like I've got to figure out these measurements to get a sense of how many weeks they are, right? So those are my fundamentals, like are they moving, how big, fetal heart rate. And, then there's the for them aspect of it of like, hey, I want to see because it's almost like a chance to visit with the child that they haven't seen yet. So it's very exciting. When I'm curious how much of the ultrasound, so in this particular case, there are some groups of people that don't want to know because for them, it's not going to change the outcome. But what you're saying is, yeah, it's not going to change your outcome, but I would really like to know because instead of us telling you we're going to deliver here, you're going to have to deliver there. They're going to have to be ready to go, the second the second you're delivering, they're going to have to know to mobilize the team and get ready for it. And that's, once again, that's a tough situation to negotiate because of autonomy versus paternalism. So that's a tough situation. But also throughout pregnancy, I find that a lot of times, and I've been through this with my wife, where, you know, like, do you want to hear the heartbeat? I have to think about this more before I discuss it on the podcast, but there's something about letting parents listen to a fetal heartbeat. I don't know if maybe it's the most tangible thing that you can do at that moment in time to make them feel connected to it. And maybe there's a sense of reassurance, but like, you know, it's not always medically necessary for them to hear it. You just have to count and make sure the beats are correct and you're not worried about fetal stress or an issue there. But, you know, definitely just like, you know, maybe a soothing aspect to parents hearing it as well, you know?
Yeah, definitely. And I always tell my patients, especially when they are hesitant to get the anatomy sonogram, I always tell them this is a beautiful test. Like you can bring actually your partner with you, and we try to accommodate for that because it's the first time that you can actually kind of see the face and sometimes the anatomy sonogram, you can, if the baby allows, depending on the position, also know the gender. If the patient decided not to get the non-invasive prenatal testing that gives you the gender via blood work, that's also a good time if they want to know. So there's also this recreational aspect to it that we also use to encourage patients that are hesitant about getting it. And as you said, like it comes it's a combo, right? Like we want to get the information that we need to give the patient the best care possible, but also there's an enjoyable part of this, and we always try to make it enjoyable for the patient, especially and the sonographers are the ones that are working on that every day. But I've never seen a patient not smiling, right, when they're seeing their baby move or their heart beating. It's a beautiful experience.
Yeah, I mean, you know, every form of medicine has its pros and its cons, and one of it in OB is, you know, the joys of that process, and it's such a low morbidity, relatively speaking. There's such joy. Everyone's happy. I mean, it's one of the few times people are happy to show up in a hospital is because they need to give birth and they're doing it in a hospital setting, you know? Yeah. Most times people show up to the hospital and it's for all the wrong reasons. So it is a really nice, enjoyable component to the field for sure. And I don't think this is evidence-based. This is anecdotal. I'm going off the cuff here with this one, but I think the harder it is to visualize the child during the sonography, that usually equates to a child that's going to come out and, you know, he or she's going to give you more of a challenge. Like, you know, the ones that aren't positioned right and they got to turn and that, you know, I think that definitely, this is not evidence-based. This is pure anecdotal evidence that I have an N of 3, a sample size of 3, God willing 4. But yes, I think that there is certainly a correlation how hard it is to get pictures of the child then and how hard it's going to be to get pictures of the child in 5 years from then, you know? So
yeah, I have to agree on that. Also with my first child, she was so hard to look at, and then she's the one that is the problem child, not the problem child, but the one that is more
she'll watch this in 20 years. So
yeah.
She's the one that's, I heard it like this. So this is, Yochi can correct me if I'm wrong. But in this community, I heard the phrase, you'd prefer to raise a chaya than a behemoth. You heard that one? So I heard this phrase from someone, and I can't advocate for it. I'm just saying what I heard from one individual. But the difference, both those are terms for an animal, but one is a domesticated, a behemoth, and one's undomesticated, a chaya. You know, they're a little bit more rowdy or whatever it is. But if you look at those kids in 50, maybe they give you a lot of gray hairs. Maybe people lose their hairs from them. But if you look at them down the line, it's generally those people that are movers and shakers. I don't know how many gray hairs you gave your parents, but, you know, that's definitely a terminology there. So, yeah, it's always a blessing. So it's definitely unique. But so we're moving on through the second trimester. We went through that pretty quickly, thank God. Hopefully we've stopped having episodes of vomiting every morning. Hopefully that stage is gone. It's not for everybody. How common is that for people to actually have emesis in the morning, to vomit during the morning during their entire pregnancy?
It's not that common, but it's not unheard of. We unfortunately sometimes have patients that they just don't stop vomiting throughout the whole pregnancy, and then we have to even sometimes do these Zofran pumps for them to be able to administer medication at home in a different way than just the oral version. But fortunately, it's not that common.
Yeah. I mean, from an emergency medicine perspective, I see not infrequently, hyperemesis gravidarum, or, that's fancy for just vomiting in pregnancy, as you said before, most commonly in the first trimester. And they're miserable, and they have to, they're basically starving. Essentially, it's starvation.
Yeah.
They have to get an IV, sugar in their IV, all these different antiemetics, vomiting medications to prevent them from vomiting, just to take them up enough to be able to continue with it. So it's tough. But anyways, we got through the hyperemesis. We've gone through the second trimester. We're in the third trimester. So I guess three main diseases that I would want to discuss quickly before we get to the end of this over here. But just so I give them all their credit and they can briefly, people should be aware of them, right? What is, these two are similar but different, obviously, placenta previa, and how does that differ from placenta abruption? I know these sound like magic words to people, so if we can break them down from their technical terms into what they actually are.
Yeah, so placenta previa is a term that refers to the actual location of the placenta within the uterus, meaning la placenta previa is when the actual placenta is sitting on the cervix, either completely. The cervix is the outlet for the uterus, which will open for the baby to be born. But the placenta sometimes might be on top of the opening of the uterus, and that's what we call a placenta previa. So in that situation, it does have implications because if the placenta is on top of the opening of the uterus, then vaginal delivery is not possible. It can be life-threatening because there can be a massive bleeding for mom. So in these situations, we need to plan for a cesarean section.
And could you see where that placenta is on your ultrasounds beforehand? Or is that it's moving and you can't really figure out where it's going to end up?
Yeah, so initially you can identify it, but it doesn't become that relevant until we have reached the third trimester. Because if you see it early in the early second trimester or in the first trimester, as the uterus expands to accommodate for the larger baby, then the placenta sometimes can move away from the cervix, and then it stops being a placenta previa. But if we repeat a sonogram, which we usually do here at 32 weeks, not only to check for the placenta location, but also to check the baby's growth, if by 32 weeks a placenta is still on top of the cervix, still a previa, then the likelihood of it moving away is very low. And that's when we start planning for delivery via cesarean section.
Placenta abruption, what is that exactly?
Yeah, placental abruption is a condition in which the placenta...
By the way, it's a nightmare for me, but obviously for the same.
Yeah, so the placenta is, as you know, attached to the uterus, and then it gets nutrients from mom's circulation to the baby. And placental abruption is when the placenta starts to detach from the uterus prematurely. Like when a baby is born, it's natural for the placenta to peel off the uterus, and then we deliver that placenta after the baby, and that's necessary. But for some reason, some patients might experience a partial or sometimes even a complete detachment of the placenta from the uterus when the baby is still not ready to be born. And this most commonly manifests itself with vaginal bleeding in the second or third trimester.
Yeah. So I mean, my classic board memory for this is placenta previa is painless, vaginal bleeding, third trimester. Obviously, with how you mentioned it, with the placenta covering the os, and then the abruption is when it kind of traumatically potentially is torn away. It can be very painful. But both of those are things that an emergency room physician does not want to be seeing in their emergency room, because obviously those are situations that really require the hands of a skilled obstetrician at that point. And the last one is preeclampsia, something that I see not infrequently sometimes when I work. What is it? Is there anyone who's specifically at risk, and what is the treatment pathway for patients with preeclampsia?
Yeah, for preeclampsia is a condition that is exclusive to pregnant patients, in which patients start to develop high blood pressures, and also they start to develop a condition that's called proteinuria, which is basically peeing a lot of protein. So protein is a nutritious element that we should not be putting in large amounts in our urine, but preeclampsia causes a dysfunction at the level of the kidneys that allow for protein to come out into the urine. So these patients can get very sick. The preeclampsia is classified in severe or mild, and depending on how severe the preeclampsia is, then the recommendation is for delivery. So the only cure for preeclampsia is being delivered, not being pregnant anymore, because it's caused by the pregnancy itself. So we have to wait and balance baby's well-being and prematurity, because sometimes preeclampsia can develop early in the third trimester, and baby might be too young for that. So if we have severe preeclampsia on a patient that is very early in the third trimester, sometimes those patients actually, their recommendation is for them to be hospitalized and stabilized to allow for a little bit more time for the baby's lungs to mature and other organs to mature. There are medications that can be given to what we call optimize the baby, like steroids, to help those lungs like mature faster for the baby to have a better respiratory response when baby is out. And if we have mild preeclampsia, then we can push that delivery time to at least early term, which is about 37 weeks. And the outcomes for the baby at that time are usually way better. So it does have a lot of implications, because it poses a risk for mom, obviously. Having high blood pressures, if the blood pressure is severely elevated, can pose a risk for strokes, hemorrhage. It can increase the risk for placental abruption, which is that detachment of the placenta from the uterus with bleeding. So it's a condition that we need to follow very closely. And depending on if it's severe or mild, severe needs to be followed in the hospital. If it's mild, then we follow those patients very closely with blood pressure checks at least once, twice a week, with blood work to check their liver enzymes as well, because it can also start affecting the liver, and you can see that on a blood test. So it's unfortunately getting more common nowadays, but in general, the incidence or the frequency for preeclampsia is about 7%, but I feel that if we look at data right now, it might be a little bit higher than that.
Yeah, and from an emergency room standpoint, when we deal with these patients, the biggest, I guess, concern that we have in the acute setting over there is that if they transition from pre to just straight eclampsia, if someone starts to seize, to give them magnesium, but that's obviously a very stressful, tenuous, high urgency situation. So, not something that anyone wants to see, but it's important to be aware of, especially with blood pressure in later pregnancy. If there's any abnormality, that obviously women should know that they should see their obstetrician for an evaluation. Now we can say Mazel Tov, the baby was delivered. That was quick. It was about 30 minutes. So probably the quickest natural delivery known to mankind. Thank God. But, two complications I wanted to talk about post-delivery. I think we can leave, postpartum vaginal bleeding probably for another episode. It's a pretty large topic, and, there's a lot of conversation that can be had. But I think two common complaints that I see in the acute care setting, or at least one more common than the other, I'll start with the less common one, then I'll do the more common one, is endometritis. So if you can kind of discuss what endometritis is, what are the implications, what does someone have to do, what would they do, why would they suspect it, what should they do if they think they have it?
Yeah, so endometritis is a condition that it's an infection inside the uterus. After the baby and the placenta were delivered, sometimes some bacteria can go in the uterus and then replicate enough to cause an infection. And it usually manifests itself with fevers, foul-smelling vaginal bleeding, or lochia, that's how we call the bleeding after delivery. A lot of abdominal pain. Patients might feel very tender to palpation. When they palpate their own abdomen, it's extremely tender, more than expected. And it's very important that if patients see any of these signs, that they seek medical attention, because endometritis can evolve very quickly into a generalized infection that can go into your bloodstream. That's called sepsis. These patients, depending on how severe endometritis is, sometimes might need to be hospitalized again and be given IV antibiotics. Sometimes if it's at a very early stage of it, some patients could be managed with oral antibiotics, although I must say that most of the time we admit those patients at least for 24, 48 hours before we let them go home on oral antibiotics to make sure that they're going to be safe, you know.
And I guess a corollary, itis, if you will, itis meaning inflammation for those who aren't necessarily aware, mastitis. So women come in postpartum, a few weeks, a few months, and they come with this tremendous amount of breast discomfort. Yeah. So what is it? What can we do about it? What do we have to be worried about if someone comes in with those symptoms?
Yeah, so mastitis is, as you mentioned, anything that ends with itis is an inflammatory process, but in this case, postpartum most of the time is due to an infection as well. So sometimes there can be some cracking of the nipple skin during breastfeeding, and that will allow most of the time skin bacteria that is normal to be there to get inside the breast tissue and then cause an infection that can get, again, very bad very quickly. Some patients might develop even an abscess and fevers, chills, generalized weakness, and this condition, depending also in which stage we find it at, sometimes might need not only antibiotics, but sometimes even an intervention like a drainage of that. If there's any pus that we can see that is collected, sometimes we can make a small incision under local anesthesia to kind of like drain an abscess that might be happening there to allow for the patient to have a 100% recovery from that.
Yeah, I mean, I certainly see it in an urgent care, acute care setting in the hospital as well. And, I think that's the biggest point is it's obviously sensitive and you approach it as delicately as you can. But the thing that I'm concerned about is if we don't treat it in a timely fashion or treat it with, normative medical treatments like antibiotics, it can go from a medical case to a surgical case, right? And the last thing anyone wants is sensitive procedures in sensitive areas that if they could be avoided, I mean, it's the last thing anyone wants to do. So I always treat those with a lot of urgency, a lot of care, a lot of consideration. I mean, thank God we have a really great callback program to make sure that we're following up. Is it getting more tender? Is it getting less tender? Is there a firmness? Do you feel a fluctuance, like there's fluid under the surface? You use the word abscess, and that's a term that I don't know if everyone's familiar with. I think a lot of people sometimes think the word MRSA when they think abscess here. Just a little education at the same time. Mm-hmm. That they think that every abscess is really called. Some people think that an abscess is called MRSA, and that they're interchangeable terms, or that that you would call it colloquial MRSA. And I have to explain that it's MRSA stands for methicillin-resistant Staphylococcus aureus, which is a very specific kind of bacteria that can create abscesses, but it's not one and the same. And sometimes you can have an abscess caused by other bacteria that are not MRSA, MRSA. And sometimes it's like basic terminology things, but it's so important because they're not synonymous. They're not the same thing. But the reason it matters is if you don't understand, or if one doesn't understand the terminology, like I've been caught unaware. I think we're having the same conversation, but I'm completely missing the point because I'm not using the correct terminology, or at least I'm not understanding which terminology needs to be corrected, and maybe a little bit of education. Definitely something that people should be aware of. We're winding down. We're hitting the end of this thing, but I do have a couple more questions for you.
Yeah, of course.
I think like this is the hot button topic. You say AI, and all of a sudden the video has 1,000 more views because you said AI. But listen, I think realistically, my everyday work has changed because of AI. I mean, some things are changing slowly, but some things are changing much faster, right? A lot of my efficiency as a physician has improved tremendously secondary to AI. And at the same time, there's a lot of hesitancy and a lot of concern about AI in the medical community. Side note, I think people believe that when we rebranded to the Izer brand, right, that it's AI-zer. It's not true. It's not true. Just because, actually, I have no idea if it's true. I don't believe it's true, but I just thought that was funny, because it happened at, I guess, around a similar time as AI as it's sprouting. But No, but it's become part and parcel of what I do to make my job more effective, be more efficient as a clinician. A lot of dictation plus AI to help generate notes, plus ambient listening programs like we have one here. It listens in on the conversation and helps to formulate your history of present illness, the first part of your note. I'm sure it's going to make its ways into other formats in medicine, certainly in the medical record, but in other ways as well. I was wondering if you had any excitement for AI, any specific hesitations? Because once again, you say AI and all of a sudden it goes up by 1,000 views.
Yeah, of course. I think that my general take on it is one of excitement. I think that it's definitely going to change not just the way that we document things, but the way that we treat patients. I don't think that we are at that point yet, and I personally don't feel that that's the way I will use AI right now. I would never use it to dictate treatment choices for my patients, but as you all said, right now is definitely already a blessing to be able to have a more efficient workflow throughout the day, because that will allow us to also see more patients. Like we have a lot of patients that need care, and sometimes we don't have enough time in the day to see those patients. So just from that perspective, it's making a huge impact, and I think that is going to be something that the patients indirectly are going to benefit from. It's still very in its early stages for other medical procedures, for example, but I think that it's also evolving very quickly. So I'm excited to see what's coming, but right now, I agree with you that on a day-to-day, the ability to use it in favor for a more efficient way to see patients is definitely already here.
Yeah, I mean, listen, I don't remember who told me this. Maybe I came up with it myself, so I'll give myself the credit. But, I believe life is a series of trade-offs. There's wins in the trade-offs, right? If you take one thing over something else, you could be net gaining. There's a net benefit, but there's also a trade-off, right? So there's pros of AI and there's going to be cons of AI. The pros of AI, efficiency might be there, accuracy might be there. There's cons. There's people who are concerned about job security, what that means for particular portions of the job. Which parts of medicine are more susceptible to being taken over from an AI perspective, similar to like an industrial revolution. Yeah. Things that we thought were absolutely necessary and people that needed to do specific roles, maybe that's not the case anymore. And that can cause a lot of anxiety, right? So I hear it. And honestly, I'm trying to just grow with it to the best that I can. I think if you have the correct Northern Star, right? If you're looking at it from the correct perspective of how do I use AI to do my best job as a doctor and help the patients the most, then you can't go wrong. It's when all of a sudden you forget that it's a tool, it's a means to an end, not an end in itself, that maybe you start using it in not the best fashion. But if you kind of consider like, I want this to benefit my team, I want this to benefit the patient, hopefully that leads to the best results, right? It's like, it's not about the tool, it's how you use the tool, right? I
completely agree.
Yeah, I see Yochi shuckling, so that means he's getting an answer. We got to finish it up, but this is perfect for the podcast. Everyone's going to know Yochi by the end of this podcast. He's going to be the most talked about person from the podcast. But ants in his pants. He's got ants in his pants. We'll help him out. We'll finish this up for you. So I think people are going to have a sense of who you are from this podcast, and that's the goal of the podcast. I want people to know who's taking care of them, because when there's empathy in healthcare, there's better results. I don't have the paper. I can't point at a paper to prove that. I'm sure they're out there. I hope they're out there. But I believe in it, and I think that's the product of having authentic, genuine human beings discuss medical care. But at the same time, you're new to the community, which is nerve-wracking, right? You have a big responsibility to take care of a really unique, special community. What are things that you're excited about? What are you nervous about? This is your tell-all.
Okay, yeah. So if I have to start with the things that I'm excited about, I must say that it's so refreshing to see how patients here care for life, like how they defend and seek life. Having babies, right? Unfortunately, that's not the case everywhere you go as a gynecologist, and I will always respect patient autonomy, obviously, and their decisions, and no matter what the decisions are, I'm there to help them, right? But it's also a little bit difficult for me in certain situations to to understand certain choices, and the choices that patients make here are more in line with how I feel about myself and the meaning of life for me, you know, and that is extremely powerful for me, and makes me so excited, you know, to really work with a population that values life the way they do. And at the beginning of the podcast, I had to mention God because everything that I've done in life and everything that I achieved, I really feel that He has been there. And when I was interviewing for this job, I was telling Mr. Mittelman that I am a God-fearing person, and I tried my best to do what God wants me to do, and not only in my profession, but as a human being, right? And what He will feel happy about, right? Like I always imagine myself waking up every day, and I tell God, like, please help me put a smile in your face. There's a lot of things that you look down. I imagine God look down to earth and then seeing a lot of sad things, right? That might make Him sad or angry, and I ask Him for His blessing to be able to put a smile on His face with my job or my existence every day. And but in that sense, I've never seen a group of people that tries so hard, right, and so genuinely to please God every day. And that to me is something that I still cannot wrap my hand around, but in a positive way. And I've been telling my family, my parents, that I want you, whenever you can, to come and feel. I hope that you feel what I feel, because when I am in this community, I feel that God is like, you almost can't touch Him, and that's how I feel. And I mean it. So for me, being part of this community and being able to earn the trust of the patients, but also being embraced as someone that, I'm not Jewish, but someone that cares for them.
We can deputize you if you'd like. Yeah.
That cares for them, and that know that I love the God that they love. And I am a Christian, and I believe in love Christ, but I love the God that they love as well. And just seeing them do what they do, that makes me want to be a better person, spiritually speaking. You know, so it's a constant inspiration to be better.
It's like inspiring inspiration, because, you know, I get inspiration from hearing that kind of, from hearing that frame of mind, from that way of thinking and way of living, and a way of considering what we see all the time in this community is special. Sometimes it's once again, when you work, you take things for granted, right? And you don't look at all those amazing things around you. But when you get to see someone who's coming with fresh eyes, and you get to see how they're looking at something, it all of a sudden is able to turn, you know, it lifts the blinders on what you're looking at, because you don't realize until someone can refocus you, like, oh, look at this amazing thing you have in front of you. So it's awesome to hear that. You know, I think all the time, you know, I wear a yarmulke on my head, and I've worn it throughout my entire medical journey. Some of it's been in areas where it's highly reasonable and normative to wear one of these. And you know, speaking of working in underserved areas, for 2 months at the end of medical school, I worked in a mixed security prison, and went in and I still put it on, and it's with me every day. And it's my personal reminder of, you know, that people are looking at me and, you know, watching what I'm doing, because I'm representing myself in a specific way. But also, you know, once again, it shows that I have a certain set of beliefs where, if I'm, you know, I hope it reinforces. I hope if there's a patient in front of me, they see that I'm wearing this, that they can have a sense of peace and safety in that, because they have to think this is a God-fearing individual, And just from knowing that I'm a God-fearing individual, that I have to do the best thing that is for them, because, that's essentially what God would want in that circumstance. So it kind of puts the onus on me to fulfill the promise that I'm essentially promising to someone by walking in with this on my head. So, but to hear it from your perspective is awesome. I had a follow-up question, but it's irrelevant after such a great story like that and such a great perspective. So, this is your firm welcome to the Iser Health family, and thanks for joining us today. I learned a lot, and I'm hoping the 3 viewers did too. And I can't wait for part 2, 3, and 4. I think there's a lot of different mini discussions we can have we once again, we fast forwarded pregnancy in 30 minutes. Who's done that before? That's amazing, right? I think there's a lot of other discussions that we can have that people are going to have, hopefully, are informative, educational, entertaining at the same time. So Dr. Herrera, welcome to Iser Health, and welcome to the Iser Health podcast.
Thank you so much for your time. It was a pleasure to be here, and I look forward to start to meet the patients at the office.
That's right. Now your work begins. This is the end of the fun. Now the work begins. All right. Thanks for coming in.
Thank you so much.